this is simply a cross-section of human bodies, not as good as that traveling road show where they actually have human bodies, but I put it up there to show all the different tissues that are found in the body. This process of dysregulated growth can occur in any of these tissues. There are some that are higher incidence, and you can probably guess now, unless I've wasted the first 20 minutes, of what tissues are going to be more likely to have a cancer occur in them, as opposed to those that have lesser turnover. So the tissues that aren't turning over a lot, cancer can occur there because there's still cell division. It's just less frequent. Brain cancers can be devastating diseases, some that are curable, but the incidence is much lower. Some of the sarcomas, the soft tissues, cartilage, bone, muscles, they can develop. Fat tissue can develop into tumors, but much less frequently. But things like the breast, the colon, the lung, those are all high turnover tissues, the skin, that are more likely to have these errors occur. Now, you can do things to accelerate the mutation process that aren't good for you. You can smoke tobacco, you can drink alcohol, you can get too much sun exposure. We're now learning that a little bit of sun is a good thing based on all that work coming out of vitamin D, but too much sun exposure, especially to people who don't have a lot of melanin, can be a problem. These are all things that accelerate the rate. But remember what I told you, even if you do everything perfectly right, the longer you live, the longer you're at risk for one of these tissues that are turning over to a greater or lesser degree to develop a tumor. And depending on where it develops, we traditionally classified the tumors based on where it developed. Lung cancer, bone cancer, colorectal cancer, prostate cancer, et cetera. Here's the incidence of the different areas. Cancers of the lung and bronchus are among the highest, and you can absolutely figure out why that is. That's because there's an industry that's been very successful at marketing their product, tobacco, that makes this a global problem, especially in developing countries. For those of you who have traveled to China and interact with the health authorities in China, they are really worried about what they're seeing. Cigarette smoking is prevalent in China, and it's growing, and the incidence, as you might expect, of lung cancer is growing dramatically. They recognize that in the next 15 to 20 years, they're going to have a huge medical challenge with this disease. There are other tissues, like breast cancer, that just are going to turn over because the breast is turning over so frequently, and the mistakes can get made there. And we know that this disease is a prevalent disease in many areas of the world. Let's talk about breast cancer as the example that we'll finish up on in terms of how we can begin to think about new therapeutic approaches based on everything I've just told you. This is a global burden disease. It used to be a disease that was really studied in the West a lot, and that's because in the developing world, it's like what we were in the 1800s. Women weren't living beyond 50 and 60, many of them dying in childbirth. Well, with good water sources, sanitation, the movement of obstetrics and midwifery into the areas, that has really made a big impact, so people are living longer. And currently, and even these data are a little dated, there are about 1.6 million new cases of breast cancer reported to the World Health Organization every year. 1 in 5 to 1 in 6 women will develop the disease. Between 1 in 10 cancers that are reported to the World Health Organization are breast cancers. There are more than 600,000 deaths from this disease globally each year. Here are the data for the United States, 200,000 new cases and about 39,000 deaths. Traditionally, we treated this disease with sort of a one-size-fits-all approach. And that one-size-fits-all approach was, if we thought it was a high-risk breast cancer, we used certain cocktails of chemotherapy to try and suppress the likelihood that there would be a recurrence and kill any cells that were left behind or had traveled outside the primary site after the surgeon and the radiation therapy had treated the primary site. But we used the one-size-fits-all approach, and it was based on where the tumor occurred. So we had a couple of menus of cocktails that we used for breast cancer, a separate group for colon cancer, a separate group for lung cancer. And it gave us some benefit, but in large part, we sort of hit a wall and kept trying to push that and never really got very far after a certain point until we learned that we can now start to query these tumors, ask them questions at a much more fundamental level and look at the genes that might be broken and try and figure that out. Now, this is 8 different breast cancers that are depicted up here. Now, you may never have looked through a microscope before, but you can see that these don't look the same. They all look different. And our colleagues in pathology are really great at describing what they're seeing in the microscope, and this descriptive pathology gives us useful information about the stage of the disease, whether it's well differentiated or poorly differentiated, things about what the nuclei look like, things about what the margins look like. So there's a diverse amount of descriptive information that we get on a pathology report. This is not useless information. Some of it carries important predictive value to telling us whether we're dealing with an aggressive tumor or a less aggressive tumor, so that we know when we want to use adjuvant cytotoxic. You don't want to treat everybody if only a small group's going to benefit because of the side effects of what our traditional one-size-fits-all therapies cause. So the hope has been using the new molecular information to really dissect what's going on and identify this variability in a much more fundamental way and develop new therapies based on that. So the idea is to have a paradigm shift and to recognize that, and we did this multiple decades ago, to recognize cancer is certainly not a single disease. There's not going to be a silver bullet. But the more important thing that we recognize only in the last couple decades, it really died hard in the field, unfortunately, but finally we've come to grips with, is even within a given organ, it's not one disease. So breast cancer is not one disease. So when a patient has breast cancer, they will come and say, my patients will come in and say, well, I talked to my neighbor, they had, their aunt had breast cancer, and they were treated this way, thinking, why am I not being treated the same way? Without recognizing that there are multiple roads to Rome. And depending on which of those pathways I was talking to you about get broken, you have a different subtype of breast cancer, and the approach to it should not be one size fits all, but should be an approach that will take into account what's really broken. So we need a paradigm that will take this into perspective. So what we've done at UCLA and many research institutions around the country have done this is to establish models of the disease. This is breast cancer. We've established a panel of some 50 plus cell lines, each cell line from a different patient's cancer. And we've made it big because we want to try to capture that heterogeneity. And we started to dissect all of these breast cancer cells that we can grow in a petri dish at the molecular level and try and understand what's broken and classify them in those that are being driven by hormone receptors like the estrogen receptor, progesterone receptor, those that are driven by other growth factor receptors, we'll talk about this one just momentarily, and those that have other pathways that are broken. And when we have a big enough spectrum of representation, we can begin to try and figure out what's broken. Now, we were lucky enough back in 1987 to identify an alteration in a particular gene called HER2, HER2. This has nothing to do with gender. This simply means human epidermal growth factor receptor number 2. So that means there's a number 1, and there is. And there's also 2 more members. They're all siblings in the same family. There's HER3 and HER4. So scientists are really brilliant in their nomenclature. And there are 4 different kinds of receptors, and they interact one with another to signal this growth signal down to the cells. Well, it turns out we were looking at these growth signals, these different kinds of antenna on breast cancer cells, and what's at the top of this diagram is 5 different tumors. They don't look like tumors, they look like sort of black bands. There's DNA from 5 different tumors that are loaded into these 5 lanes, and the exact same amount of DNA is put in each lane. And we go in and probe with a probe that'll tell us how much of the HER2 gene is there. And sure enough, you can see, if you've even never looked at one of these before, it's very variable, even though we put in the same amount of DNA, meaning a mistake has gotten made. There's too many copies of this gene in these other tumors. This is a non-inherited alteration, one of these mistakes I told you about, where the Xerox machinery copying the DNA gets stuck on a part of the blueprint and makes too many copies of something that's not supposed to be there. at that level. Well, it's a growth factor receptor, and guess what it does? It's one of the accelerator genes. So it makes more of the RNA, it makes more of the protein, and the cells have a lot more. Each one of these little cuboidal things is a different cell in the tissue, and you go from tumors that don't have the alteration to tumors that do have the alteration. Does it mean anything? Well, first of all, it occurs in about 20 to 25% of all breast cancer globally. So of those 1.6 million new cases every year, 20 to 25% have made this mistake in the breast tissue sometime during the life of the individual. Does it mean anything? Well, here's what it means. The women whose tumors contain these extra copies make too much of the protein, and they have a very different outcome when they're treated with the one-size-fits-all approach. So the median survival, meaning the midpoint, some patients live much longer, some shorter, is 6.8 years if the HER2 gene is normal. But if it's amplified at any level, that drops to less than half when they're all getting exactly the same treatment. So already we know we're dealing with a different subtype of the disease. Can we do anything about it? Well, this simply shows you outcome curves. Now, I'll just take a moment to explain this slide a little bit more. This is a sobering slide. It is an outcome slide based on survival or recurrence. So you have a diagnosis, you have the tumor. When you start the study, 100% of the patients have their tumor removed and there's no evidence of tumor anywhere else, and they're alive. But as you follow them out over time, and this is measured in months, you can see that there is a deterioration of the curve. These are the recurrences and the deaths that occur in the patients that are challenged with the disease. But when we look at the molecular pathways, you can see that immediately it breaks itself into 4 different groups. A group that has some deterioration earlier on, but ultimately it levels off and they have a pretty good outcome long term. Another group that doesn't do quite as well, they have different sets of genes that are broken. A group that has yet a different set of genes, and this group down here in purple or pink is the HER2 alteration. They have the worst outcome. Now, if we know this, can we do anything about it? So remember, these patients had among the worst outcome of having a recurrence or death from their disease, usually within 3 to 5 years. Well, when you break out the breast cancers in general, the biggest piece of them are the hormone receptor positive breast cancers. And going back, that's the dark blue and the light blue. And some of these don't do as well. Some do even worse, but still there are some that do pretty well. And it's the hormone receptor pathways that are broken here. So our therapies maybe should be directed there. In the HER2 gene group, it's the HER2 gene that is broken. Our therapy should be directed there. So one size fits all is wrong and shouldn't be the way we approach the disease. If we do that, we'll make a difference. So what we did in the laboratory is we took these HER2 positive breast cancer cells and we asked if we mimic in a lab what's happening in patients, what happens to the cells. So we took human breast cancer cells that don't have the alteration and we engineered them by introducing the gene in multiple copies, making the mistake that has happened in the patients, forcing that mistake in a cell in the lab to mimic in the lab what was happening in patients and ask what would happen. And what you see is here. We've taken these HER2 normal cells that are shown on the left and made them HER2 positive, and then we can look at their growth rate. How fast do they grow? Ignore all the other parts of the slide for a moment except for this, the lower right. We put the cells in culture. They're genetically identical except one has the HER2 alteration and one does not. Here's how many cells are in the culture in terms of numbers of cells over time, shown on the bottom in days. So this is the proliferation of the cells. These are the HER2 normal cells. These are the cells that are otherwise identical. They came from the same patient except we engineered them to have the alteration, and the proliferation is way greater. And you can see the same thing here, HER2 normal versus HER2 positive growing in a petri dish. We can do this in experimental animals and show that they'll form tumors much more readily, and those tumors will be much more metastatic, telling us that this thing is tracking with a bad outcome because it's playing a role in causing that bad outcome. That makes it a logical target. So the validation of that was to say, can we inhibit it? So what we did was we treated tumors in experimental mice, and I've been admonished by Robbie not to show mice so that the The animal people don't get after us, but they're important for us. But I will show you the growth curve. Without these animals, we would not be able to do this experimentation, except till we get the patients. This is tumor size in growth. This is now growing in a living organism in a mouse. This is a human breast cancer growing without this specific treatment, which is an antibody directed against that growth factor receptor. It works like a blanket that you throw over the antenna so it stops receiving signals. When we put the antibody in, this is the growth of those cells. They won't form tumors. So armed with this data, we went to the US FDA and asked for permission to start phase 1 clinical trials. Initially at UCLA and then at multiple institutions. And the true heroes, or I should say heroines in this story, are the women who enrolled in the clinical trial that made it all happen, that really developed a new therapy with a drug that Jim told you about. This is the generic name, trastuzumab. It's Herceptin. It's the antibody that is very specific for HER2 positive breast cancer. Using it in HER2 normal breast cancer doesn't cause much of an effect, but in the HER2 positives, it can completely suppress the growth. So does it really lead to a difference in outcome in terms of using this information to develop more effective and less toxic therapy? Well, remember this curve, and this is the HER2 group and how it behaved previously. Now I'll show you outcome data from a huge study of several thousand women who were followed over time that were treated with different modalities, going back in our, quote, modern era of oncology. This is, now you become expert at looking at these curves. 100% of the patients are alive at the start of the study, and over time, and this is measured in years, only 26% are left without a recurrence or death. That's when we treated them with just cutting the tumor out and radiation, nothing really more than that. And that goes back more than 50 years when we treated tumors that way. When chemotherapy came in, a scientist by the name of Gianni Bonadonna in Italy found that adding chemotherapy to the high-risk patients improved the outcome to this. This is a significant difference in a huge global problem in terms of the numbers of patients that are saved. There are variations on the theme of chemotherapy that made a little difference. Then we found a new chemotherapy drug, something called, we didn't find it, it was discovered by scientists initially at the NCI, something called Taxol that made a pretty big impact in terms of really improving outcome. And we had variations on the way of using that chemotherapy. So we were doing much better than 26% of the patients. We're up to now 65% or more. But that's treating everybody one size fits all. If we take the HER2 positive patients, and remember those are the ones that had that outcome data that looked like this, like this, crashed here, and we add this drug Herceptin to their therapy, this is what we get. So they went from becoming the worst outcome to becoming the best outcome with targeted therapy. So this personalized approach to figuring out what's broken and treating the patients appropriately can result in this. And we think we can do even better than this. We have new data we'll present in a month that has taken this number from 84% up to 92%. So this is the kind of thing that oncology is moving us toward. And we're doing this in the other big subtype now, the hormone receptor positive. I won't dwell on this other than to say there's a new therapy that's under evaluation now at our center, but all the community centers that we set up, and with our colleagues in the community who are doing these clinical trials, that's taking these aggressive tumors in the hormone receptor positive ones, the dark blue and the light blue, where you did see a fall off, those patients need help. And when we look at that, we've got outcome data that I'll just show you the last curve and then we'll stop, that look like this. There's an improvement of threefold in terms of the progression for them. This doesn't mean everybody's dead at the end of the trial. Don't take it that way. That simply means we've followed out this far. And we've updated the data, and we have this now so that there is a tripling of the progression-free survival. The patients who are treated with our best available approved standard therapy, we're having a median progression-free survival. Their tumor behaved and didn't progress or cause death. The median was 7.5 months, treated with our best available standard therapy. With this new experimental therapy, we now are at 26.1 months, more than 2 years. So we're not talking about 2 weeks or 2 months difference. We're talking about a huge difference. And for those of you now, you're all experts at reading these curves. The median, the midpoint, has been hit for the best available standard therapy. The midpoint has not yet been hit for the experimental therapy at 2 years plus. So this is now in phase 3 testing at the centers that we've set up in the community, and that's where we're at. So the hope is that the further translation of this biologically relevant molecular information will lead to even more effective and less toxic therapeutic approaches. I'll stop on that point, and I'm sure I've still gone way over time, but I wanted to tell you where we're at in the field, where we're heading, what we're doing. What you just saw for breast cancer is true for lung cancer, colorectal cancer, prostate cancer. All of these things are now being approached at this molecular level to identify what's broken and to personalize the therapy to the pathways that are altered and really direct our therapy there as opposed to non-specific bombs. We still use chemotherapy. We still use radiation therapy. They are important pieces of our armamentarium in the fight against this disease, and they do benefit huge numbers of patients. But we can do better, and we can develop therapies that are more effective and less toxic. With the Herceptin story, I can tell you the women who were on those first trials with Herceptin thought we were giving them a placebo because they had no hair loss, no nausea, no vomiting, no side effects at all when we gave the drug by itself. It's only when we added the chemotherapy and that we got all the other problems that you see with chemotherapy. This is going to be the paradigm that will be rolling out over the next 2 to 5 years across a number of malignancies. It already is, and it's already reversed outcome data for some of our most devastating cancers. So stay tuned, you're going to see even more of that. What I'm going to do now is turn the podium over to Dr. Glaspie. He'll give you a brief summary of his perspective of where we're at and some of the things we changed, and then we're going to open it to the panel and answer some of the questions that came from the audience. We won't be talking about specific cases tonight, so we can't tell you what you should get treated with next personally, but we'll talk about it in more general terms. John, here's your...